What can patients expect from their rhinoplasty consultation?
We're going to be taking a full medical history from a physical or a functional point of view. Some people have irritant rhinitis.
That's my favorite question. When I ask patients, do you have rhinitis or sinusitis? They look at me like deer in the headlights, like, I'm like, okay, so the answer would be no. Do you always break the bone?
We break the bone in reductive rhinoplasty, where the nose is being made smaller, because if you reduce the nasal bridge and don't adjust the width of the nose can appear wider.
Is breathing always at risk for being impacted by rhinoplasty?
Breathing is always at risk by rhinoplasty because you're making the nose smaller.
How much of rhinoplasty do you deem to be artistic?
All of it. It's an artistic expression. All cosmetic surgery is an artistic expression. Hi, everyone. Welcome back to another episode of Unfiltered. Today, we're going to be talking about rhinoplasty from A to Z. I'm going to turn the mic over to Nancy, who's going to ask some questions.
Hi, everyone. So today I thought we would chat about rhinoplasty surgery from the consultation to through the surgery and to the end of the recovery at the end of the year, and go over the process that you can expect to experience. So let's start off with the consultation. What can patients expect from their rhinoplasty consultation?
So rhinoplasty consultation usually takes place either in my Thornhill office or down here where we are today at Davenport. Patients are assessed by myself as well as usually one of our nurses. We're going to be taking a full medical history, finding out about what's brought the patient in, both from a physical or a functional point of view, and whether they have any aesthetic desires as well. Some rhinoplasties may be functional in nature, meaning the patient had trauma or breathing issues or prior nasal surgery. Other rhinoplasties can be purely cosmetic in nature. I'd say probably the majority of the cases that we see have a combination of some functional component as well as some aesthetic issues. Then we try to not only figure out the patient's motivations for surgery, we want to take a thorough history about their overall health history, whether they've had other prior cosmetic surgery, and whether they were actually happy with the other cosmetic treatments. Frequently, rhinoplasty patients are the starting age is young, so early, mid-teens, so 15 and up for females, 16 and up for males. So we just want to make sure that they're not only physical candidates for the procedure, but that they're emotionally ready for the procedure and that they understand the risks and the nature of the surgery recovery time, are not only prepared for it, but are aware that it's a process. So
that's a key fact.
It's a big fact. Yeah. All surgery is a process, but rhinoplasty in particular is a process that can take up to 12 months. So we tell patients up front, we're going to be evaluating them for candidacy for the procedure. We're going to be taking a thorough history. We're going to be doing a full physical examination, which can include the external nose, as well as sometimes we examine the intranasal anatomy with endoscopic equipment, like a fiber optic telescope we sometimes use. Sometimes we just look in with a headlight just to assess the structures of the nose. The internal nasal anatomy is anatomy that patients aren't familiar with. A lot of people have heard the word septoplasty, and that's referring to the partition wall inside your nose. So we're going to be evaluating whether the septum is sitting in the midline or whether it's off to one side.
Is it true that they say 80% of people's noses have a deviated septum? What is the statistic on that?
I don't know if there's a full or a clear understanding of what percentage of the population have a deviated septum. I think a lot of people believe they have a deviated septum or told they have a deviated septum, but it may be that they have other things going on in the nose. Someone could have nasal allergy, they could have nasal polyps, they could have a mild deviation in the nasal septum. Some people have irritant rhinitis, where they have almost like a non-allergic type of phenomenon. It could be due to just environmental pollution. They may have a legitimate allergy due to dust or mold.
That's my favorite question. When I ask patients, do you have rhinitis or sinusitis? They look at me like deer in the headlights, like, I'm like, okay, so the answer would be no. So anyways, just back to the consultation. We also take photos of the patient so that you can do some imaging.
Right. So after we've done the full history, physical examination, both external nose and internal nose, we'll take photographs. Yeah. And we find this particularly helpful as a communication device to allow the patients and myself to look at the nose critically from different angles. So there's standard photography used for rhinoplasty. It's usually 6 images, one from the front, one from the base of the nose, called a basal view, lateral views, and three-quarter views. Yeah. And they're all important for assessing the nasal aesthetics, the alignment of the nose, something called the dorsal aesthetic lines, which are the lines that run down the sides of the nose, that often are captured by shadows and lighting in professional photography and model shots. So those are important sort of evaluations just to see whether those need to be addressed during the rhinoplasty. Then we determine in my practice whether the patient would be best suited for one of two procedures. One is a open approach rhinoplasty. The other is called endonasal or closed rhinoplasty. Third type of procedure would be called a preservation or drop-down rhinoplasty, and we perform all of them. Some patients are different ethnicities, so if the patient happens to be African American or Asian descent, we may be talking about dorsal augmentation where we're building the nose higher, versus Caucasian patients, we're often talking about reduction rhinoplasty, making the nose smaller. And there's different considerations. So an augmentation or dorsal augmentation rhinoplasty in African American Asian patients, then we talk about whether we want to use cartilage or rib is the most frequently cartilage graft that we use, versus using a synthetic implant known as Gore-Tex. And these are big topics that be discussed for, on their own, but those are kind of the practical considerations. So again, history, physical examination, possible nasal endoscopy, photo documentation, photo analysis. Physical analysis, part of the physical examination of the nasal anatomy, involves looking at the aesthetics, how it balances with your face. Also mathematically, we look at angles, lengths, widths, projections, alignment. And then finally, we look at skin type, which also is a significant factor involved in determining candidacy for rhinoplasty, but also setting expectations. So patients with thick skin may have, we have to set a different expectation. Some patients with poor quality skin may have limited benefit from rhinoplasty and may require additional treatments such as post-surgical treatment with cortisone shots. We sometimes use 5-FU, and occasionally we recommend the use of Accutane, which is an acne medication, but has been implemented by rhinoplasty surgeons to address some of the thick skin patients and to improve the surgical outcomes that we provide. So it's a lot of little things, but those are kind of the, I don't know, just top of my head. That's the big picture. Then we determine sort of opportunities to do the procedure either in our clinic, which is a fully set up facility for rhinoplasty, or some patients prefer to do it at the hospital. There's pros and cons to doing clinic versus the hospital. There's also differential pricing depending on which location they choose to do the surgery. Patients ask me, why is it a different price? Well, our anesthesiologists are part of the pricing, the nursing staff's part of the pricing, and the facility fee at my own office versus the hospital incurs different pricing. So we give different options. So not to overly complicate things, but I like giving patients flexibility. So we give 4 prices: endonasal or closed rhinoplasty, open rhinoplasty quotation, hospital quotation, and private facility quotation. They're all slightly different. And then we basically determine which, best suits our given patient. So not everyone's a candidate for all of them. We may say you need 100% to have a open rhinoplasty, or we may say you're on the fence, we could do the procedure either way, and there's pros and cons to each. So you may next ask me.
I know what I'm asking.
You ask me next.
I have a few other questions regarding the consultation. Then we're going to move on to the surgery portion of the program.
Sure.
So as far as the consultation, what can patients not expect?
I think in terms of not expect, I think it's, we want to set realistic goals. So I've been doing this a long time, and after 25 years of doing rhinoplasty, I can say there is still an element of unpredictability on what we can achieve surgically, because it is a process. So I tell everyone there's the surgical planning, there's the execution of the operation, then there's the healing, which I don't have total control over, and then we have to assess how the patient's skin responds to the surgical changes to the framework, meaning the bone and cartilage. And then there's time, which is really important. Patients need to give their nose a lot of time to really evaluate the full outcome. That could be 1 year to 12 to 18 months. Sometimes even longer on certain patients. Patients can't expect us. They can't just bring in a model or a celebrity and say, this is what I want. They can certainly use it as an inspiration photo. So we say, if you want to send us an email with all the inspiration shots, sometimes they show us examples. It's helpful. Yeah. And it may set the stage for me in terms of my surgical planning, whether they want a more conservative approach or whether they want to have a more aggressive approach, a more stylized nose, a more button nose. All of those things are important, but ultimately they're just inspirations. I can't necessarily 100% guarantee they're going to get what they're showing me, but hopefully we can move towards that goal.
I think you just said the key word, guarantee. Patients come to us and they're like, I want this. And we say, hope that that's the goal. but people do often want the guarantee.
Yeah, there's no guarantees with any, because
guarantee.
there's no guarantees with any surgery you get
Right.
done. I mean, there's guarantees we'll do our best efforts and then we'll work with you to ensure that we get the best outcome possible. Some patients require more than one operation to achieve the best results. So our goal is to do the procedure and hopefully we achieve the results after one operation. Some patients, up to 5 to 10% of patients, may require a minor touch-up. Major touch-ups, usually less than that, probably like 1 to 2%. Minor touch-ups can be, depending on which surgeon you see and whether they are reflective and analyze closely their own statistics, usually up to 10%. And that could be further refinement, further narrowing, further reduction of the bridge, managing subtle asymmetries, slight bumps on the nose, thickening of the nasal tip, which we hope to improve and give more definition. And some of those are just the nature of the procedure, just depending on how you heal. Any surgeon who doesn't tell you that, I think, is being somewhat misleading, to be honest, because most of the surgeons who are real with their patients have been doing this a long time. We all chat about challenges of rhinoplasty, and all of us are faced with the same types of challenges. We have patients saying, oh, my friend went to Turkey or Iran and got a perfect result, and 3 of their sisters did. But we see on a daily basis, you can attest this, patients coming from having surgery in Iran and Turkey needing touch-ups.
Yeah.
So and some of them have great jobs done, but they still need additional work. So that's a whole separate discussion, whether patients traveling abroad are going to achieve a one and done perfect result. There's certainly no guarantees to that either. It's one of the advantages of having surgery locally. If there is an issue, we certainly can address it and do our best to work with our patients.
What do you look for in a patient before you take them on as a patient? When we're meeting them in consultation, maybe what are some red flags? What would veer you off of wanting to do surgery on somebody?
I think that's a great question. I think that what patients don't necessarily understand is while they're evaluating us to determine whether they want us to do the surgery on them, we're evaluating them, determining whether we want to do the surgery on them as well. And so the healthy relationship is that there's a match. The patients choose you because they like your work or they have some confidence in your expertise and the amount of time you've been in practice, see lots of examples of your before and after, maybe you have friends or family who've come to us. Those are all healthy motivations to seek a certain doctor to be their caregiver. From the physician side of the equation, the physician is looking that the patient is realistic, that the patient seems rational, reasonable, that they'll be easy to work with and collaborate with if things don't go perfectly well. So those are the types of things that we're looking for. There's a whole list of things that are called red flags for plastic surgeons.
Tell me about some of the red flags.
So surgeons have a lot of red flags that we look for when we're evaluating a patient for candidacy for cosmetic surgery. Some that come to top of mind would be patients who seem unrealistic in terms of their expectations and goals, patients who push back on what you're recommending and say they're not satisfied with it. That's an automatic no-go. You should automatically put a pause on things. We've done that many times. Patients who are haggling over price can be a red flag. Patients who are not accepting of a potential need for a touch-up procedure is a red flag. Patients who are rude to your staff is a red flag. Patients who have body dysmorphia or seem to have multiple or tons of cosmetic surgery, who don't seem to have a real sense of their outcome or maybe hypercritical of their surgical results, even if they're good.
Anxiety and depression?
Anxiety and depression are mild red flags. I wouldn't say they're massive, like complete contraindications of surgery, because so many people in our society have some form of anxiety, and we see some of our most happy, gratified patients who do have those. I think when I trained, those would have been considered no-go red flags, but I think they're hard to, first of all, be able to fully evaluate on a patient. And some people are well medicated and treated adequately for anxiety or depression. So it's almost not fair to sort of hold that against them as long as their mental health is stable. So I guess unstable mental health would be a red flag. Those are some of the ones that come to mind. Borderline personality disorder can be one where a patient's telling you they're gushing over you and saying you're the greatest doctor in the world, but equally may flip and be hypercritical of you as a doctor as well. So many surgeons stay away from borderline personalities if they're able to evaluate that adequately. In a initial consultation, sometimes can be very difficult to fully evaluate a patient's psychological profile.
But sometimes the big picture, the front desk can have an experience with the patient, the consultant will have an experience with the patient, you'll have an experience with the patient, and sometimes we do have a review at the end of a consult day, and we sort of talk about the patients and all the cases that we met. And if a few of us sort of indicate that we had an experience or an interaction with the patient that might have been a little bit uncomfortable, then we can at least it can help us better identify it.
Yeah, no, for sure. And we take that all seriously. And in circumstances that sometimes I'll think a patient seems amazing and the staff may have concerns, we may bring the patient back for a second opportunity for them to communicate with us, because some people are just nervous in their consultation. So we try to give everyone the benefit of the doubt, but at the same time, we are getting into sort of a marriage with the patient. So we don't want to have a bad divorce with the patient. We'd rather avoid getting married to the wrong person up front.
If more people could do that.
Yeah, but I think those are sort of some of the main ones that come to mind.
So I want to talk about we're at the consultation. I want to talk about, I want to whip through a few more topics. So that would be the surgery, the process of recovery. I call it a marathon because it can take, the surgeries day one, and then there's 364 days to follow, which can be hard for people to wrap their head around. They're into that when they want to book surgery, and then it becomes harder for them after surgery. So let's talk about surgery itself. Do you always break the bone?
I'd say the vast majority of rhinoplasties do require some adjustment to the nasal bones.
And why do you break the bone?
We break the bone in reductive rhinoplasty, where the nose is being made smaller, because if you reduce the nasal bridge and don't adjust the width of the nose can appear wider. And an analogy would be a pyramid, where you take the top of the pyramid off, like a plane flies into a pyramid. It's no longer a pyramid anymore until you move the sidewalls in to make a smaller pyramid.
Okay,
so we're trying to restore that. Yeah. In circumstances where there's just a slight amount of bony changes and slight reduction in the nasal bridge, sometimes we can avoid what's called osteotomies, but I'd say that's probably less than 10% of our cases.
Is breathing always at risk for being impacted by rhinoplasty?
Breathing is always at risk by rhinoplasty because you're making the nose smaller. So sometimes adjustments to the intranasal anatomy is critical to avoid breathing problems. So some people have a septoplasty as part of the rhinoplasty, and they may say, I didn't really have breathing problems before, but then we want to avoid them having breathing problems afterwards. So sometimes we're doing some subtle changes to the septum to avoid breathing problems, whereas if we ignored the septum and left it unchanged and maybe mildly deviated but not symptomatic, but we're worried when we make the nose smaller, and if we leave the septum anatomy deformed and distorted, the patient may develop breathing problems at a later date. So some of it's almost preventative. We're trying to ensure the function's adequate while we do the cosmetic work.
How much of rhinoplasty do you deem to be artistic?
All of it. It's an artistic expression. All cosmetic surgery is an artistic expression because it can be subtle, and millimeters can make a big difference in terms of the way that we see the harmony of the face. So, and again, that's why it's a very fun operation, because you can be creative in the pursuit of making the patient's outcome as good as possible.
Let's talk about the recovery. It's not easy for some patients. Some patients have no problem. So let's say somebody comes to us, their next follow-up after a splint removal is, we see them about 6 weeks, and they're struggling a little bit. It's still a little wide, or it's still not looking exactly as they like it. How do you navigate that?
It's tricky. I mean, we're here for reassurance, and I think patients who have good information and feel supported by our office won't go down some kind of spiral where they start getting extra stressed out. So the more communication, the more open we are for dialogue and to nip the anxiety in the butt is helpful. Patients want to know that if they do develop an issue, that we're here to help resolve it. We do tell patients that, honestly, in the initial few months of healing, we're not too reactive, because if you see, say, a little bit of a bump forming on the bridge, that could be a callus formation on the bridge.
How about asymmetry?
Similarly, asymmetry. So we're going to have to give the nose time to really do its thing, because we don't want to assume just because we see. I've seen patients with a bump forming or asymmetric nasal bridge 3 months postoperatively, and then seen them at the 1 year mark and it looks perfect. So
that's a lot to navigate, though, for somebody who's got it on their face. Is the central characteristic on the face is the nose. It's hard, I'm sure. I've never had a rhinoplasty myself, but I hear it from the patients. Us reassuring them is one thing. What other advice do you have?
Honestly, that's the main thing, is just being supportive and making sure the patients feel that we're that we're validating, hearing their concerns, and that we're here to resolve it to the best of our ability. I think patients start to spiral if they feel ignored or blown off.
Right.
Now, some patients spiral. Some people spiral about things that I don't even see. Sometimes someone will come in with something that is expected, like normal swelling postoperatively. And then it's about it's about a trust thing. If they sort of lose confidence in you or get very anxious, sometimes it's very, very challenging. We've had the odd patient who's fully spiraled at month 3 and then being hugging us with like joy at month 6.
It's true.
So we see all sorts of things. So
Yeah,
again,
it's
I
true.
think the patients have to really go into this operation realizing it is a process.
Yes.
I'd say probably 80 to 90% of the patients are relatively straightforward from a psychological perspective, as long as we sort of pick each other at the beginning well. I think the patients that we struggle with are patients that have complicated anatomy, ones that have had multiple surgeries, ones that unfortunately have difficult anatomy and poor healing. And sometimes we're disappointed. We're here to sort of do our best, so we would recommend surgery. There's been cases that I want to go back and revise and the patient doesn't want to. And vice versa. I have some patients wanting a revision when I think it looks great. So you sometimes have to use time as your friend and navigate the situations, because some things, you have the physical part of the rhinoplasty as it changes and morphs through time. And then you have the moving psychology as patients become used to their new nose and recognizing themselves with the new nose. So some people may have a nice nose job and like just not be used to the way they look for a while. The brain has a bit of a catch up. So it's roughly 12 months till you have your final nose job. But you may take a year or so, even longer, to really like it and see yourself with that new nose. Especially people who've had radical changes, big changes, may take longer. And that's assuming everything's perfect. Then you throw in a little bit of healing issues and sometimes needing a little adjustment. So I think overall, most people seem to understand that, and they're able to go through, be mature about it and give it the time. The odd person, I'd say more frequently, some of our younger patients may be less patient.
Yeah, I would be.
It's a longer period
hard.
of time from
Yeah.
as a percentage of their life
age
lived.
of 16 to the age of 17.
Yeah,
That's like a lifetime.
It's a lifetime, right? So for them, it's a big deal waiting. So and the other thing I'll mention is parent support, because
That
sometimes
was my
we
next
have
question. How important is that? How important is the support system around them?
the support system is critical, because we sometimes see patients who are doing okay, and then we'll have the mom or dad saying, "What about this? What about that?" And they put them into a spiral, or put them into a psychological orbit that they're like doubting or
That's
whether
a hard
they should
thing.
have done it.
When we see kids and they're happy and the parent is like, I don't know if I like this. And it's like, oh my God, you just hope that they don't say it to their child, who's actually quite content and easy to please. It can happen.
Well, it's amusing because sometimes we see people whose moms have had surgery when they were kids, say commonly overseas in Iran or Turkey. And the mom may have like a tiny, tiny nose, which was sort of in style in the 80s, or maybe viewed as a nice result. And the child is more Canadianized, and they want to have a little bit more of a classic rhinoplasty, not a scooped out, a little stronger nasal bridge. So there's a disconnect between the aesthetic judgment of maybe the parent and the kid. And so who do we please? We have to aim to please the patient, obviously, but sometimes you end up in this 3-way negotiation between the mom and the daughter and myself.
Do you take it personally when someone comes to you and said, I don't like my nose after you've done surgery?
I think it's hard not to take things personally if the patient's respectful and the patient recognizes you're doing best. Then I'm completely trying to depersonalize the situation. Then I try to be as objective as possible and look at the result critically and say, can I improve upon this? And the patient may be right. There may be issues that need additional attention. I'm completely open-minded with that. I think doing this a long time, right from the beginning, we tell patients you may need additional work to get the result you want. It's on all their paperwork. I mean, we obviously don't want that if at all to avoid it, but that's just the nature. That's the nature of rhinoplasty. There's surgeons, international, world-famous surgeons who've written textbooks. We sometimes see some of these patients floating around country to country looking for revisions. That's just the nature of it. I don't take those personally. You take it personally when the patient loses confidence in you and thinks that you may not be the right surgeon for them. And that happens very infrequently, but when it does happen, then you're trying to sort of regain trust and make sure that the patient believes in you and that you're able to navigate them to the point that you achieve the result that you set out to do, because your goal is to make them happy. And so if a patient's unhappy or they're not satisfied and you think you can improve upon it with additional work, which is sometimes just the nature of it, you want them to still work with you rather than go somewhere else. Most surgeons feel the same way, that if they can improve upon a result, they want to be the one to do it. They don't want someone to go somewhere else.
I would say you're 25 years into your career, so you're pretty much at the peak of your career. Is there anything more for you to learn or evolve or grow in rhinoplasty surgery, would you say?
It's an interesting question, because rhinoplasty surgery throughout my 25 years in practice has changed a lot. Some of the core basics have still maintained themselves. There's been an evolution of procedures and some technology. There's been the use of ultrasound cutting devices called piezo, which was added in during my practice life. There was the preservation techniques, which was a quantum shift in the approach to rhinoplasty. And I think all of these are still evolving. I think as a plastic surgeon doing facial plastic surgery, you have to keep an open mind to always be learning. That's one of the curses and gifts of being a surgeon, is that you have to you have to maintain your excellency in the field, but also keep an open mind, because sometimes new techniques come out that are superior. Deep plane facelift I adopted over a decade ago, and I think my results are way better as a result of it. Preservation rhinoplasty, to me, is a tool that I use in very select cases. Some surgeons use it for all of their operations. I think in my practice, I like having all the tools that come out and become an expert in all of them, so that there's no gaps in my ability to provide the care. Some surgeons don't feel that way. They rather stick with limited toolbox and try to just perfect their limited toolbox and offer similar procedures throughout their entire career where they feel they're excellent at. I feel like in order to be excellent in rhinoplasty, you have to have a little bit of an open mind to use different techniques for different clinical situations.
And my last question, which isn't really so much a question, but a statement, at this stage of your career, you being one of the top rhinoplasty surgeons in Toronto, you are being inundated with patients coming from all over Canada, the United States, and internationally now. How do you feel about that? I
feel like we're fortunate that we're very busy, and that patients have put trust in me to do their surgery, and that we get some accolades in patients traveling from different cities. I will say there's more and more well-trained surgeons working throughout different parts of Canada. We used to get a lot of people, and we still do, from areas such as Newfoundland, where there may have been less surgeons focusing on rhinoplasty, to Victoria, British Columbia. So it was a huge distance for people to travel. It makes you feel good that you're providing a specialty service and that your reputation has spread across the country. So yeah, it makes you feel good that you're doing good work and that it's being recognized out there in society. So I guess it's a bit of an ego boost for us. Okay, that was a great episode. We covered a lot of material. I hope it was informative, especially for those of you out there contemplating rhinoplasty surgery. And we will see you shortly for another episode of Unfiltered.